The main condition that I treat is degenerative diseases of the spine, cervical spondylosis or lumbar spondylosis. Spondylosis is just that, the name we give to wear and tear of the cervical spine, the neck, or the lumbar spine, the lower back. Of course, there are many other conditions other than degenerative spine, and so younger people can be affected by prolapsed intervertebral discs, giving rise to low back pain and leg pain. So the age of people can be from somebody in their late teens the whole way through to people in their 90s. Because somebody is young doesn't mean to say that we shouldn't be doing everything we can to relieve their back pain and their leg pain. And similarly, somebody in their 90s can be quite troubled with pain in their back, pain in their neck. And there are things that can be done other than surgery that can alleviate this pain. And it's the role of the spine surgeon to pick the way through the various treatment options and arrive at the simplest thing to get the maximum result. Most of the people come to see me because they are in pain. Sometimes one can have weakness of an arm or weakness of a leg without pain. However, that's a rarity. Most of the people that I see come to see me because of neck pain associated with arm pain or with low back pain associated with leg pain. And that can be due to a variety of things. And it's the job of the spine surgeon, such as myself, to dissect out the history, to work out the likely diagnoses that exist, to embark upon appropriate investigations, to arrive at the correct diagnosis, and then to discuss with the patient the various treatment avenues that are open to them so that we can manage the pain in the most effective and simplest manner. The ideal way of working with a general practitioner is for the GP to actually give me a ring right from the outset, so that he can say to me, Peter, I've got Mrs. XYZ sitting in front of me. She's got some neck pain and arm pain. It's been present for the last week or so. What should we do initially? Do we embark upon investigations right from the outset? Do we send it to a physiotherapist? How do we manage it? A lot of the time, you don't need a surgeon. You can be treated with an anti-inflammatory agent, with some painkillers, maybe some gentle stretching from a physiotherapist, and oftentimes the situation will gradually settle down of its own accord. If the general practitioner wants to give me a ring and to discuss the management, then that gives him more confidence that he's doing what is appropriate, and it also gives a patient more confidence that there is the surgeon in the background ready if a referral is necessary. If the conservative treatment doesn't settle the problem down, then it's an easy thing for the general practitioner to give a second call and say, doesn't seem to be settling, can we have an appointment so that you can see the patient face to face? A patient should know enough about their condition to enable them to make a sensible decision as to what management plan they want to embark upon. Sometimes a patient will come and see a spine surgeon and they may have an idea in their head that doesn't exactly apply to the condition from which they're suffering. It's the role of the spine surgeon to take the history, do the investigations, and then explain to the patient what it is that's going on and what the options are. It's sort of like doing a bit of window shopping. You're going around the management shop and you're seeing what options are available to you. Do you just continue with conservative modalities of treatment? Do you embark upon some injection therapy? Or do you embark upon surgical intervention? And it's the role of the spine surgeon to explain to the patient what the various complications of the various avenues are, what the results might be, how successful are they, and in that way the patient can get enough information, hopefully, so that they can make a decision to manage the problem in a way that best suits them.